Hey, good morning and welcome to the UroPatient podcast. I'm your host, Vic Sinise. Welcome to the show. If you're watching us live, great. Glad to have you on board. We come to you every Saturday at 10:30 a.m. Central Time, and we come to you on Facebook and YouTube and X. If you're watching us on YouTube or Facebook, be sure to like and subscribe to our channel. Also, if you're here for the first time, be sure to check us out at our website at UroPatient.com, where you can learn more about the show anytime you want. Also, best place to go to watch all of our past episodes, and we got a whole bunch of them in there now for you. 65, I think. And it's also a good way to get some nice handouts for you to take to your doctor's office when you got a question or two. So go to our website and you'll find our handouts. So this week we're going to be talking about renal cell carcinoma. So last week I talked about renal or kidney cyst. Today we're going to be discussing renal cancer, what it is, the latest treatments, and survival rates. My goal is to help you understand your options and give hope through medical advancements. So renal cancer or kidney cancer starts in the kidneys. Those are these two bean-shaped organs that you see right here. They filter waste from the blood and they produce the urine. The most common type of kidney cancer is called renal cell carcinoma. Now, early detection is crucial. Symptoms can include blood in the urine, lower back pain, unexplained weight loss, and fatigue. That's feeling tired. Some cases are asymptomatic, meaning you don't even know you have them, making regular checkups vital. Now, doctors use imaging tests like CAT scans, MRIs, and ultrasounds to detect tumors. Many are found incidentally during a study for another issue. Blood and urine tests can also help assess kidney function. Early detection through these methods improves treatment outcomes. This is a picture of a CAT scan that you're looking at right here. And these were colored to make it easier to see, but this is the kidney tissue, this stuff in pink here. And then this green is what a tumor would look like on a CAT scan. So you can kind of see it almost kind of built into. Okay, you remember those cysts I showed what they look like? Well, this has more solid material in it, which is what makes it more suspicious for being cancer. Now, renal cancer is staged from 1 to 4. Stage 1 is localized, while stage 4 means it has spread. The most common sites for kidney cancer to spread are the lungs. That's the most frequent site, often presenting with multiple nodules in the lungs. And next, the bones. Bones can cause bone pain, or we call it these fractures where the bone gets brittle and it'll break, or spinal cord compression. That can cause spinal paralysis. And the liver, which may lead to jaundice, liver dysfunction, or abnormal liver enzymes. Can also go to your lymph nodes. Enlargement of affected lymph nodes can occur. It also goes to your brain sometimes. That can cause neurological symptoms like headaches, seizures, and confusion. And the small glands that sit atop the kidneys are called the adrenal glands, and they are also a common early site that can have metastasis. So stage 4 means it spreads to any of these other organs. Staging is what we use to help determine the best treatment plan. So surgery is often the first-line treatment. A partial nephrectomy removes just the tumor, while the radical nephrectomy removes the entire kidney. Hey, good news, folks. You only need one kidney to survive. So you've got 2 good kidneys, and if you lose one, you can live a normal life, long as you've got 2 good kidneys to start with. But the other thing is, by doing a partial nephrectomy, why wouldn't you just take the whole kidney? Imagine if you did have that kidney removed and you got into a car accident and now you lost your kidney. Well, then you're down to nothing. So at least a partial kidney may be all you need to survive also. This is how it's done. You can kind of see this area right here is where the tumor's at, and they just try to slice a margin past that to get to good tissue, cancer-free tissue. And then they can take these 2 halves, bring them together, and sew it like you see here, leaving you with a partial nephrectomy. More and more, that seems to be the option of choice, is to try to leave somebody with part of a kidney. Some tumors are amenable to that. Not all are. Now, there are all sorts of options for treating besides surgery. and it's something called targeted options. So targeted therapy uses drugs to attack specific cancer cells while sparing the healthy ones. An example of this includes things, and these are fancy names, I know, tyrosine kinase inhibitors like sunitinib and pazopanib. So those are fancy names too. All the generic names, and these cancer drugs are always tough to say, but we'll take you through them a little bit, what's meant by targeted options. So these two drugs, and their marketed names are Sutent and Vetroriant. Even those aren't so easy to say, but they're what we call tyrosine kinase inhibitors, or TKIs. You'll hear that term thrown around. They're commonly used as first-line treatments for advanced or metastatic renal cell carcinoma. So even when it's spread, we can still use these drugs. Both drugs work by targeting the vascular endothelial growth factor receptors, and that inhibits tumor growth, or we call it angiogenesis, but that means new tumors growing, and slows the cancer progression. It doesn't cure it, but it can slow it down. Now, the sunitinib is taken in cycles with periods of rest, while pazopanib is taken continuously. Studies suggest similar efficacy between the two, but the pazopanib is often associated with fewer side effects like fatigue and hand-foot syndrome, while sunitinib may cause more gastrointestinal issues. The choice between them depends on patient tolerance, comorbidities, and physician preference. Your doctor is going to guide you to what they think is best. There's another group of drugs out there called immunotherapy. And immunotherapy boosts your own immune system to help fight cancer. And these are called checkpoint inhibitors, and they help the body recognize and attack cancer cells. The reason most of us don't get cancer is our own immune system, when these abnormal cells form, are wiping them out just like that. But when that system goes awry, sometimes a good boost to it will help. They work by targeting the PD-1, or programmed death 1 receptors, on the T cells. T cells are part of your white cells, enhancing the immune system's ability to recognize and attack cancer cells. Both medications can cause immune-related side effects, but they provide promising outcomes for patients with metastatic renal cell carcinoma. Radiation can be used, but it's used less frequently because it generally doesn't work, but may help when surgery isn't an option. Chemotherapy is generally less effective for renal cell cancer, but is sometimes used in advanced cases. So you may have heard of these things. That's always been the problem with renal cancer. Caught early, removed before it spread anywhere, and your chances of surviving are much greater, because the chemotherapies, like there are for other cancers, just are not very effective. Now, the ones that I mentioned before are new drugs that have come to the surface that have really improved the outlook. So research is advancing rapidly. New drug combinations and personalized medicine approaches are improving outcomes. Clinical trials offer hope for patients who qualify, and the outlook for renal cell carcinoma has significantly improved since I started urology back in the 80s, due to these advancements in early detections, those targeted therapies we talked about, immunotherapies. In the 80s, treatment options were limited mainly to surgery. The radical nephrectomy, really, the partial nephrectomy, came along after I'd been practicing for a while. And metastatic renal cell carcinoma had a poor survival rate, with a 5-year survival rate of about 10 to 15% for advanced cases. Not very good. Chemotherapy, as I mentioned, and radiation therapy, largely ineffective. Now today, the 5-year survival rate for localized renal cancer exceeds 75 to 90%. And even in metastatic disease, where it's spread, newer treatments have extended survival significantly. Targeted therapies like those tyrosine kinase inhibitors that we mentioned, and the immune checkpoint inhibitors, have revolutionized treatment, improving response rates and overall survival. Additionally, improved imaging techniques enable that early detection, which is so key, catching it before it spread anywhere, leading to better outcomes. Overall, renal cancer is now far more manageable, with longer survival and better quality of life than back in the days when I first started in the 80s. Many patients live fulfilling lives after renal cancer. Lifestyle changes like a healthy diet, exercise, and regular follow ups are essential. And there are even support groups out there that can help provide emotional and practical help. Well, I hope you really enjoyed the show. It's hope got a little bit of hope if you've got cancer, kidney cancer. It's survivable, maybe even curable, and caught early. That's the whole key. And it's always good to know that there's a lot of new treatments options out there for you. So join us every week to learn more on UroPatient.com.